Welcome to another Thursday, an academic hour brought to you by the Academic Subcommittee of the GMOA. Today, we have a very young and energetic consultant who will be discussing about one of the main problems around the world, which is also a cause for global health burden, chronic kidney disease. So today we have with us Dr. Dilushi Wijayaratne, who graduated from the Faculty of Medicine, University of Colombo, with first class honors. She was board certified as a specialist nephrologist in 2020. She is currently a lecturer in the Department of Clinical Medicine, Faculty of Medicine, University of Colombo, and an honorary consultant at the National Hospital of Sri Lanka and the National Institute for Nephrology, Dialysis and Transplantation, Maligawatta. Currently, she is reading for a PhD in population health at the University of Oxford. So, I would like to invite Dr. Dilushi to enlighten our learned audience for the next 1 hour or so on CKD. What do you need to know? Also, to all of you participants, I would like to say that questions will be taken in. So during the lecture, if you do have any questions, please be kind enough to drop it off at the chat box, and we will be discussing your questions and discussing the points once the lecture is done. So Dr. Dilushi, it's over to you.
Thank you very much, Dr. Rajiv. First of all, I'd like to thank the GMOA for giving me this opportunity to talk about a very important subject, which is chronic kidney disease. And again, I'd like to remind you that you are most welcome to pose any of your questions, and they will be answered at the end of the lecture. So the topic that I have today is chronic kidney disease. What do you need to know? And this is the outline of my talk. So first of all, I'll be focusing on the definition, the diagnosis, risk stratification of CKD, identifying complications, what we can do to delay progression, about kidney replacement therapy, screening and prevention, which I think should really be a priority, especially in a setting like ours. So first of all, let's think about what we mean when we say CKD. Chronic kidney disease is defined, just as the name implies, as something that is chronic and evidence of kidney disease. So kidney disease can be an abnormality of either the kidney structure or function. And to demonstrate chronicity, we should be able to show that it has been present for a minimum of 3 months. And there's also an additional component to this definition, which is that there should be implications for health. So there should be some important consequence in terms of health for a patient who is diagnosed as having CKD. So how do we demonstrate an abnormality of function of the kidney? The best way of doing that is looking at the glomerular filtration rate. Now, we can't measure GFR because that is too complicated. What we do is we estimate the GFR based on measurements of blood markers such as the creatinine or cystatin. So creatinine is what is commonly available to us, and what we do in our daily practice is measure serum creatinine and then calculate an eGFR based on what we find. And I'll be talking a little bit about how we do that in some of the next slides. How do we demonstrate a structural abnormality of the kidney? We look for evidence of albumin in the urine. So albumin is not normally there in the urine in health. If there is albumin, it means that there is something structurally wrong with the kidney, usually some damage to the glomerulus. Of course, there are other ways of showing that there is structural damage to the kidney. For example, if you were to do a scan on a patient and find that there's only one kidney, or to do a scan and find that there are polycystic kidneys, that also would be evidence of structural damage. And sometimes patients have renal biopsies, which again show structural damage. But in our day-to-day practice, again, it's the albuminuria that we generally concentrate on. So when we are defining CKD, the most important components are the eGFR, which is estimated by the serum creatinine, and the albuminuria. So based on our albuminuria and our serum creatinine derived eGFR, we are able to categorize patients into different stages of chronic kidney disease. Now, the reason to do that is because by identifying which category the patient falls into, we are able to predict how likely this patient is to develop end-stage kidney disease or how likely this patient is to develop cardiovascular disease. Because in the end, what matters to patients is the clinical outcome rather than the creatinine level or the albuminuria level. So as you can see in this diagram, which is a heat map, right? On the left-hand side, you can see EGFR categories. I wonder if there's a way to get the pointer. Sorry, on the left-hand side, you can see the EGFR categories. And the GFR is graded from 1 to 5 based on what the EGFR is measured at. So if your GFR is more than 90, your stage of CKD based on the EGFR is G1, and the lower your GFR is, the higher the stage based on the GFR. Similarly, we also have an albuminuria based risk stratification from A1 to A3. So having no albumin in your urine is the best possible outcome, and then the more albuminuria you have, the higher the stage. So as expected, the lower your GFR and the more albumin you have in your urine, the more likely you are to fall into one of these red boxes, which indicates a high risk of going into end-stage kidney disease. And the higher your GFR, that means the better your function to start off with, and the lower your albumin, the less likely you are to progress to end-stage kidney disease. So people who have a GFR of above 60, but no albuminuria, are not considered to have chronic kidney disease, right? But when the GFR falls below 60, or once they start to demonstrate albuminuria in their urine, then we diagnose them as having chronic kidney disease, provided we can demonstrate that this is a chronic process and not something acute. So, what is the local epidemiology of chronic kidney disease? Our country has a difference in epidemiology based on the geographic area that you are considering. If we consider the Western province, the epidemiology is very similar to the rest of the world, where diabetes accounts for most of chronic kidney disease, with almost half of the cases of CKD being related to diabetes. The second most common cause is hypertension. And then there are other causes like glomerular diseases and polycystic kidney disease. So as you are well aware, diabetes is so common, hypertension is so common, and all of us are at risk of developing diabetes and hypertension. So for one thing, we need to prevent diabetes and hypertension, and then we need to manage it properly so that patients don't develop CKD. In other areas of the country that are highlighted on this map, we have a condition called CKD-U, which is of unknown etiology, possibly related to various contaminants and toxins in the water, but still of unproven cause. And the prevalence of kidney disease in these areas is very high. However, because we don't have a proper registry in our country, we don't still understand the true burden of chronic kidney disease. And this is something that the Ministry of Health as well as the Society of Nephrology is trying to initiate in our country so that we can really understand what is happening in terms of the epidemiology of CKD. Okay, so we now understand how to define CKD. How do we diagnose and risk stratify? So let's look at a case. This is a very typical case, often being referred to a nephrologist, but doesn't really need to be referred to a nephrologist. A 75-year-old man referred for evaluation of renal impairment. He has well-controlled hypertension managed with amlodipine. Blood pressure is 128/72. His routine checkup shows his serum creatinine to be 1.4. And let's say that on the lab report, the range is given as 0.8 to 1.3. So he has been asked to see a kidney doctor immediately, as is often the case. And the doctor is very anxious and asking if he is going to need dialysis. So our first question is this actually chronic kidney disease? So what more information do we need? So when we talked about diagnosing chronic kidney disease, we said we need to demonstrate that there is functional damage or structural damage and then chronicity. How do we demonstrate functional damage? By calculating the EGFR. So based on the creatinine values that we have for this patient, a creatinine of 1.5, age 65, a male, we can input these values into a calculator which uses this equation called CKD EPI 2021, which is the standard equation used to calculate the EGFR, and then calculate the glomerular filtration rate, which comes as 56 milliliters per minute. So these calculators are available online, and then they can be done basically at the patient's side. So based on this, we can see that the GFR is less than 60. So this does fall into the category of functional damage to the kidney. We also want to see if there is structural damage. So we measure the urine albumin-creatinine ratio. The urine ACR is 2.5 milligrams per millimole, which is normal, right? And the ultrasound scan is also normal. So there is no evidence of structural damage in this patient. There is only functional damage. How can we demonstrate chronicity? So the best way of demonstrating chronicity is to look for any previous evidence of kidney disease. So we can look at his past records. If someone has been interacting with health services for a while, it is very likely that they will have had a serum creatinine checked. So we can see if there have been any serum creatinine tests done before. Has there previously been a UFR showing albuminuria or a urine ACR showing again albuminuria, all of which would be evidence of chronicity. If we aren't able to demonstrate chronicity with previous records, then we can look for other features of chronicity. That is, does the ultrasound scan show features of chronic damage to the kidney, small kidneys with increased echogenicity and loss of corticomedullary demarcation? Or are there established complications of CKD like anemia, CKD mineral bone disease, or on physical examination, hyperpigmented skin and nail changes, which can be seen with advanced chronic kidney disease. Again, we need to ask ourselves when we are evaluating a patient like this, is there a reason to suspect an AKI? For example, is there an acute rise in the serum creatinine, right? Is there a reduction in urine output? Or is there a risk factor for this patient to develop AKI? So a patient who is just walking into the clinic routinely is less likely to have an AKI, but a patient who is being referred from the hospital is more likely to have an AKI. And some risk factors are drugs and toxins, ongoing infections, and so on. Right, so now in our patient, this 65-year-old man who had a GFR of 56 and no albuminuria, he doesn't have any previous records, so we aren't able to compare it with anything else to demonstrate chronicity. He does not reveal any reason to suspect an AKI. Is there any reason for him to have CKD? So we can ask ourselves, is his history compatible with CKD? He's aging, so his age is 65, he's got hypertension, so yes, he is at risk, which means that can explain why he has a reduction in GFR. And we follow him up for 3 months just to make sure that yes, his GFR does remain below 60, and it does. And then we can see that he falls into this category of G3A-A1 on this heat map, which is chronic kidney disease. So I did mention that when a patient has chronic kidney disease, or when we are diagnosing a patient as having chronic kidney disease, one of the other things we need to consider is whether there are implications for health. That means, does it actually matter to the patient in terms of clinical outcomes? And here we have another more elaborate heat map on the left, which shows how various clinical outcomes correlate with this EGFR and ACR stratification. So just at a glance, you can see that as the GFR falls and as the albuminuria increases, the risk of dying, the risk of an MI, the risk of cardiovascular death, stroke, going on renal replacement therapy, heart failure, all of that increases. Even at this level of GFR between 45 to 59 without much albuminuria in the urine. So yes, it does seem that there are implications for health. The implications are not necessarily going on to end-stage kidney disease. And in fact, in this particular category of G3A1, which is probably the largest proportion of patients with CKD, the most important clinical outcome is really cardiovascular death and cardiovascular morbidity. So when we're managing these patients, one of our main focuses needs to be improving cardiovascular risk. Okay, so I hope the diagnosis of CKD is clear. Let's move on to another case where we talk about how we risk stratify these patients. Imagine a 75-year-old man who is now again referred to us for evaluation of renal impairment. He's a bit more multimorbid than the other patient. He has a history of ischemic heart disease. He had a coronary artery stent done 5 years ago. His ejection fraction is 40%. He has hypertension, dyslipidemia, and he has knee joint osteoarthritis. And his current medications are aspirin, atorvastatin, enalapril, atenolol, and furosemide, so the usual cardiovascular drugs. He has a routine checkup and the creatinine is 2.8 milligrams per deciliter, which we put into the EGFR calculator and we find his EGFR is 23 milliliters per minute. So this is CKD stage 4. Right, so again, he has been asked to see his kidney doctor immediately. And again, the question comes up, is he going to need dialysis? So this man has been interacting with the health system for quite some time. So he has a previous creatinine. 6 months ago also his EGFR was 22. So this is stable. And his urine ACR is 8 milligrams per gram, which is normal, right? And it's very common for these patients with ischemic heart disease, atherosclerotic disease, to have non-albuminuric chronic kidney disease, right? So is this CKD? Yes, it is, because its GFR is low and we have been able to demonstrate chronicity. How are we going to answer this question about whether he is going to need dialysis? What is the impact on this patient? So apart from these CKD heat maps that we have been talking about, now there has been a tool that was developed to predict the kidney failure risk based on various parameters that we can measure. This is called the kidney failure risk equation. And this calculator is also available online. So you can use the web address that's given here, and then access this calculator and input the details. So a 75-year-old male from non-North America with an EGFR of 28, albuminuria, urine ACR of 8. We can calculate the risk of going into end-stage kidney disease at 2 years is 2.78%, at 5 years it's 10%, right? So these are rough estimates, of course, and there's a certain amount of uncertainty about it, but you can see at 2 years the risk is not that high. By 5 years it's high, 10% is quite high, but this is a 75-year-old man with ischemic heart disease that we're talking about. So then the question arises, is it more likely that he is going to die of ischemic heart disease before he reaches end-stage kidney disease? And probably again in the setting of this patient, that is quite likely. Now, if this was a younger patient, for example, someone in their 30s who had this same risk prediction, then we would be more worried, because we know this patient has a longer time to live, and therefore, even though the risk at 10 years may be 10%, at 5 years maybe 10%, in another 5 to 10 years that the risk is going to be quite high. So how you interpret this result will really depend on the age of the patient that you are dealing with. So moving from diagnosis and risk stratification to management, how do we identify complications in these patients and how do we delay progression? So again, let's try to approach this problem by considering another case. This is a 68-year-old man with type 2 diabetes, hypertension, ischemic heart disease, referred for evaluation of reduced kidney function. He feels generally well. He's a bit tired. He notices some ankle swelling in the evenings. His blood pressure is 160/90. His EGFR is 35. It was 38 a year ago. So there is a decline, but it is in keeping with his diagnosis of diabetic kidney disease. His urine ACR is very high, right? So it's 1000 milligrams per gram, and his UPCR is also 3.5. So if we think back to those heat maps, he's at high risk of progressing to end-stage kidney disease. His hemoglobin is 9, which is low. His MCV is normal. His calcium is 2.1. His phosphate is 1.5. Both of them are normal, but at the lower limit and upper limit respectively. And the serum albumin is 3.2. So it's a little bit low. So when we are managing a patient like this, we have to consider what are our aims. In any patient with CKD, one thing we want to do is identify and address the etiology. That requires specific management. So if it's diabetes, you manage the diabetes. If it's glomerulonephritis, you will have to manage the glomerulonephritis, and so on. Then there are non-specific strategies to delay the progression of CKD and reduce cardiovascular risk. And cardiovascular risk is so important because, as we saw, many of these patients are going to die of cardiovascular disease rather than chronic kidney disease. And the two go hand in hand, really. Then we need to look for and manage any complications. And if, despite our best efforts, we are not able to delay the progression of CKD, we need to prepare patients for kidney replacement therapy. So identifying and addressing the etiology is quite a specialized area. Right? If it's diabetic kidney disease and it's typical of diabetes, then you don't really need to refer to a nephrologist. But if you're not sure, or in other cases, it's probably best to refer to a nephrologist so that we really understand what the cause for the kidney disease is and we can institute any specific management. I've just mentioned diabetes here because it's so common that if you do have a patient with diabetes, you would want to aim for an HbA1c of less than 7 usually with appropriate drugs. And what I mean by appropriate drugs is drugs which are suitable for that particular GFR, which are not likely to cause hypoglycemia. The treatment is very individualized. Once we have reversed and controlled the etiology, we have to institute general measures to delay the progression of CKD and reduce cardiovascular risk. So these are broadly lifestyle changes, blood pressure control, lipid lowering, and SGLT2 inhibitors and RAS inhibition. So this is very familiar to you. This is not something unique to kidney disease. This is something we do for any patient who has a high risk of cardiovascular disease. And these same strategies help to delay the progression of CKD as well. So if we talk about lifestyle, what do we need to advocate for? It's basically a healthy lifestyle, a healthy diet, increasing physical activity to at least 30 minutes of aerobic exercise 5 times a week, stop smoking, and maintain an appropriate weight. And I'm just going to spend a few more seconds talking about a healthy diet. So very recently, we had a new guideline published on the management of chronic kidney disease. And in this guideline, they have very helpfully given us a guide to what patients can eat rather than what patients should not be eating, which is what we have been focusing on for the last few decades. So what we think is a healthy diet now is a plant-based diet as much as possible. That doesn't mean that you give up animal-based food, but the balance should shift towards plant-based food, plant-based protein, unprocessed, so fresh food as much as possible, low in salt, that's less than 2 grams per day, right? So what we generally tell our patients is that's less than a teaspoon of salt per day across all meals, which means that as far as possible, you have to try to eat food prepared at home and avoid any kind of processed, packeted, tinned food. So this really applies to all of us who should be aiming for a healthy diet for the reduction of our own cardiovascular risk. When it comes to protein, the recommendation is about 0.8 grams per kilogram per day. Again, more plant protein than animal protein if possible, and avoid a high protein diet. There are some drugs that are on the market called keto analogs, which can be used to supplement a very low protein diet to avoid malnutrition. So these keto analogs should not be just prescribed blindly, right? They are only of help if you are able to institute a very low protein diet of 0.3 to 0.4 grams per kilogram per day. By themselves, they have no therapeutic action. Right, so from lifestyle moving on to blood pressure control, how low should we aim? Our guideline in chronic kidney disease is to aim for a systolic blood pressure of less than 120 because we are very kind and we want to protect the heart. So this is not for delaying the progression of CKD. It's because we are worried about the cardiovascular risk in these patients. Now, this mainly applies to what is called a standardized office blood pressure, where you measure the blood pressure in the office under very strict conditions, which we hardly ever can do. But what we can do is ask our patients to take home measurements and bring them with them when they come to the clinic, so that then we can see if the home measurements are roughly around 120 or a little lower. we are happy with their control. And the recommendation is for, say, 2 morning and evening blood pressure measurements taken during the first week of every month. Right? So this target is applicable across all patients. But again, if the patient is very frail, if the patient is at high risk of falls and fractures with very limited life expectancy, or if they have postural hypertension, then we would not want to aim for such an aggressive control of blood pressure because the adverse effects would be more. In CKD patients, our preferred agent for blood pressure control is an ACE inhibitor or an ARB. So ideally, if there's no contraindication, they should be on one of these drugs. And then if we still haven't achieved our target, we can add on another drug. Moving from blood pressure to lipid lowering. So for lipid lowering treatment, if the GFR is more than 60 and there's no albuminuria, we don't consider them to have CKD. But everybody else who falls under the diagnosis of CKD, that is albuminuria of more than 30 or a GFR of less than 60, should be on a lipid lowering treatment if they are over the age of 50. That is because of cardiovascular risk, right? So we can use statins, or we can use statins in combination with ezetimibe. But this does not apply to dialysis patients who probably would not be patients that you would be caring for commonly. So patients with CKD are a little bit more vulnerable to the side effects of statins. So generally we prescribe a slightly lower dose, around 20 milligrams of atorvastatin, 10 milligrams of rosuvastatin. And if you are given simvastatin with ezetimibe, the doses are as shown on this slide. Now, there are some very important renoprotective drugs that are available to delay the progression of CKD, which also reduce cardiovascular risk, right? So, one important category is SGLT2 inhibitors, which have become popular over the last couple of years. Patients with albuminuria, so this is albuminuria of more than 200 milligrams per gram, as you can see, should be on an SGLT2 inhibitor, right? Even if the eGFR falls into the normal category. So even if the eGFR is 45 to 90, which we think is very good, if they have albuminuria of more than 200, they should be on an SGLT2 inhibitor. If patients have a GFR of 20 to 45, that means they have lower kidney function, then regardless of the level of albuminuria, again, they should be on an SGLT2 inhibitor. The evidence is stronger, or the patients are more likely to benefit if they have more albuminuria. But even those with lower levels of albuminuria have been shown to have some benefit from being started on a SGLT2 inhibitor. So what are these SGLT2 inhibitors? They are drugs like dapagliflozin and empagliflozin and canagliflozin, right? So they are available now. Still, they're not available for free in our government hospitals, at least not as far as I know. But they are available in to be bought from the private pharmacies, and they're not that expensive. And hopefully, they will be available in our hospitals as well soon. So this is something we really should be promoting, because they are fantastic drugs which delay the progression of CKD, reduce cardiovascular risk, and so on, right? At any GFR, if there's albuminuria, patients should also be on an ACE inhibitor or an ARB. And just to re-emphasize about SGLT2 inhibitors, though these drugs were designed as drugs for treatment of diabetes, their effects in CKD are general, and they even among patients who don't have diabetes. So it's not restricted to patients with diabetes. So we need to remember that very frail and very old patients were excluded from these trials, and these are drugs which have become popular quite recently. So we still don't have a lot of experience with the SGLT2 inhibitors. And therefore, in that category, we might ask ourselves, we might think twice about starting them. And we need to ask ourselves, what are we trying to achieve? Right? So this kidney failure risk equation, as an example, is helpful in prognosticating to avoid what may be unnecessary treatment. So if a patient is at low risk of progression to end-stage kidney disease within their expected lifespan, it may not make sense to start them on just yet another drug when they are not likely to have a clinical benefit. Okay, so SGLT2 inhibitors are great drugs, but there are important messages that I want to highlight because we don't want patients to be taken off them unnecessarily. So, as soon as you start a patient on an SGLT2 inhibitor, there can be an acute reduction in EGFR. And this is because of the hemodynamic effects of SGLT2 inhibitors. Much like you can get an acute reduction in EGFR with the ACE inhibitors or ARBs. So, how do we identify an acute reduction in EGFR? We'll see that the creatinine has gone up, right? So, an up to 25% change is okay. And it's important to tell patients this because some of them are very anxious about their creatinine reports. And then if they see that the creatinine has gone up, they may stop the drug. Or they may go to another doctor who will then stop the drug. So you don't want that to happen. It's best to explain to them that this is something we expect and that the advantages of taking the drug will be in the long term. Also, when you start a patient on an SGLT2 inhibitor, they will start to pass glucose in the urine because what these drugs do is they inhibit the reabsorption of glucose in the proximal tubule of the kidney. So it's important to tell patients that this is not diabetes. Just because they're passing glucose in the urine, that doesn't mean they have diabetes, but that they are at risk of getting fungal infections in the perineal area, and therefore they need to wash that area with water every time they pass urine. So not with soap, because if they use soap, they will distort the normal flora, just with water. And also we advise these patients to discontinue the drug during acute illness on what we call sick days, because the benefits of these drugs are long-term rather than in the short term. And in the short term, when they are ill, they can get certain complications. Right, so that is how we approach delaying the progression of CKD in general, that is non-specific management. Now we also need to look for and manage complications of chronic kidney disease. And I'm sure you may be quite familiar with these complications because the kidney does certain things, and when the kidney is not working properly, then these abnormalities can arise. So patients can get anemia, they can get what is called CKD mineral bone disease, acidosis, hyperkalemia, hyperuricemia, and what we call uremia. So if we start with anemia, what do we mean when we say anemia? The definition in CKD is just the same. So generally we say anemia for a woman is when the HP is less than 12, and for a man it's when the HP is less than 13. But remember, all anemia in a patient with CKD is not due to CKD. Now, why do patients with CKD get anemia? Mainly, it's because the erythropoietin production from the kidney is less. But of course, there are many, many other reasons why patients with CKD get anemia. Having said that, we have to realize that every anemia in a patient with CKD is not because of CKD. Therefore, we have to ask ourselves, is the HP too low really for that degree of kidney function? Or is the HP dropping much faster than we would expect in someone with this kidney function? And if we do suspect that, we need to evaluate the patient. So with basic tests like blood, like a history and examination first of all, of course, and then a blood picture and hematinics. And we may even need to refer to hematology if we have any other concerns. But if we are quite sure that this is due to CKD, or once we have excluded other things, we can treat according to symptoms and severity, right? So there's no threshold, there's no HP level below or above which, an HP level below which we would treat patients. Often it goes by the clinical picture. So if patients have symptoms of anemia, then of course that will be grounds to treat. So first thing is we will replete the iron stores. We will look at the TSAT and the ferritin, right? And then if these are our targets, so we want a transferrin saturation of more than 30 and a ferritin of more than 500. So these are slightly higher than in other patient groups. That is because patients with CKD need higher levels of iron to achieve the same hemoglobin. So in early stages of CKD, we can give oral iron, but in later stages, often we need to give it IV. Now, we do have what are called erythropoiesis stimulating agents, right? And erythropoietin is what we commonly use. And usually ESAs are not recommended if the hemoglobin is more than 10, right? Our aim is for an HP less than 11.5. So basically, we're trying to have an HP of between 10 to 11.5, definitely not above 12. And that is because these ESAs have been linked to strokes and various other thrombotic events. So we don't want to prescribe a patient something like erythropoietin and then target a hemoglobin of more than 11.5. Our aim would be something like 10 to 11.5. Generally, we try to avoid blood transfusions in patients with CKD because they are heading for a transplant often. And when we transfuse patients, they can get sensitized. Then they are at risk of rejection, or they might find it very difficult to find a suitable donor. But if patients are older, they're not going for a transplant, then of course we can be a bit more liberal with transfusion. CKD mineral bone disease is quite a complicated topic, but as you may know already, and as shown in this diagram at the top, when the kidney is not working properly, there's less activation of vitamin D in the kidney, and there's less phosphorus being excreted from the kidney, and all of this leads to the parathyroid hormone being secreted in excess. And what does PTH do? It acts on the bone, and it causes release of calcium into the circulation. So one of the features of CKD mineral bone disease is high PTH, or hyperparathyroidism. One of the types of CKD mineral bone disease is hyperparathyroidism, and that is associated with low calcium levels and high phosphorus levels. So indiscriminate use of calcium supplements, phosphate binders, and vitamin D analogs may do more harm than good. And the reason I've emphasized this is that often we see that as soon as a patient is diagnosed with CKD, or as soon as a patient has a creatinine of 1.3, slightly above normal, they will be started on calcium and vitamin D. So what happens when we start patients on calcium and vitamin D is, as you can see in this chart at the bottom, on the bottom right-hand side, calcium and vitamin D is now going to suppress the release of PTH and cause what is called low turnover bone disease. Now it's going to the other extreme, and this is completely iatrogenic. And when PTH goes down, the patients go into this state of what is called adynamic bone. And then we continue giving them calcium and vitamin D. And because the bone is not turning over, the calcium can't get into the bone. It gets into extraskeletal sites like the heart and the vessels. And that is associated with an increased risk of cardiovascular disease. So indiscriminate use of these drugs does more harm than good, right? What the recommendations are is to try to lower phosphate levels towards normal if they are persistently rising. So it's not really to achieve a normal phosphate level, but moving towards normal if they are going up, right? How do we do that? With a low phosphate diet. Low phosphate diet is generally avoiding processed foods. So that's the first thing that you have to mention to them. And phosphate binders, which have to be taken with meals. So often we see patients on calcium carbonate as a phosphate binder, but we have forgotten to tell them that this needs to be given with the meals so that the phosphate in the meals can be bound. If they take the calcium carbonate between meals, they will now absorb the calcium and they will absorb the phosphate, and now both of those will get deposited in the deposited in the vessels, which is the opposite of what we want to be happening. All right. So we also want to avoid hypercalcemia, right, which is why we should not be indiscriminately prescribing these drugs. And ideally, we should be doing PTH to guide our treatment. So we know that if the PTH is very high, we are at this extreme of high turnover, right? So that's when we want to be given these calcium-containing binders and vitamin D. But if the PTH is very low, then we don't want to be given these drugs. So without looking at the PTH, we can't really just look at the calcium and phosphate levels and understand what's happening, right? So again, this area requires more evidence, but usually we say that the target is somewhere between 2 to 3 times the upper limit of normal. So just like with the iron, in CKD patients, we are not aiming for a normal PTH. We are aiming for a PTH between 2 to 3 times the upper limit of normal. So PTH is available, at least at the NHSL, right, and perhaps in other hospitals. So we should try to do these tests, especially I think on the younger patients who have a longer life expectancy and are more vulnerable to these problems of CKD, mineral bone disease, and cardiovascular disease. Right. So another complication of CKD is hyperuricemia. It's important. There was an idea at one time that lowering uric acid levels would delay the progression of CKD, but now the evidence has been reviewed, and we don't think that, at least at the moment, there is enough evidence to support that particular practice. So we don't have to actively look for asymptomatic hyperuricemia. What that means is, if you have a patient with CKD, you don't have to check the uric acid levels unless the patient has symptomatic hyperuricemia, and that is generally gout. If the patient has gout, we can start a xanthine oxidase inhibitor like allopurinol. And of course, we don't like NSAIDs. So if a patient has acute gout, we should avoid NSAIDs. So metabolic acidosis is another problem, right? And again, in this particular area also, we used to believe that correcting metabolic acidosis would delay the progression of CKD. But again, that evidence has also been reviewed, and now we don't believe that any longer. So the recommendation is really to treat with sodium bicarbonate if the bicarbonate is less than 18. Okay. So these particular guidelines came from an era when there were no drugs really to delay the progression of CKD. But now we have RAS inhibitors, and even more than RAS inhibitors, which have been there for a long time. We have SGLT2 inhibitors. So there are other things we should be concentrating on rather than these. Hyperkalemia is a very challenging problem sometimes with these patients, and one of the difficulties is that often these patients with CKD are multimorbid, like they may be having diabetes, they may be having ischemic heart disease, heart failure, and therefore they may be on medications which have potential prognostic benefit, like RAS inhibitors, which are associated with hyperkalemia. So you can imagine a patient with heart failure who is on losartan, who has a potassium of 5.6. Now what are we going to do about it? We want to keep the patient on the RAS inhibitor, but we're worried about the potassium. So what we should try to do is to keep the patient on the drug as far as possible. So address any correctable factors. So look at the other medications that the patient is on and see if there's any other explanation for why there can be hyperkalemia, like NSAIDs. Look at the dietary intake and see if that can be modified. And look at then you can adjust or add medications to bring the potassium down. So we can use diuretics like furosemide. If there's metabolic acidosis, we can correct it with sodium bicarbonate. So this might be an instance where, rather than waiting for the serum bicarbonate to fall to less than 18, we would try to correct the serum bicarbonate to the normal range if it is not within the normal range. And then we can use what are called potassium exchange agents. So what is available to us is calcium resonium, which we can try. And only as a last resort should we actually stop the RAS inhibitor or reduce the dose. So you might try to reduce the dose first before you stop it. And stopping it is not the end all. At some point, we have to review the patient and try to start the drug again, right? Because the reason is that they have much to gain from being on these drugs. So again, when it comes to hyperkalemia, nowadays, the recommendation is for patients to focus more on plant-based foods, less on animal-based foods and processed foods, because the absorption of iron from animal-based foods and processed foods is very high, and these foods are more acidic, so the serum potassium levels also tend to be higher. Whereas with plant-based foods, the absorption of potassium tends to be less, right? And these foods are generally more alkalotic, so therefore the serum potassium tends to be lower, because there's a connection between your level of acidosis and your serum potassium. So if you're becoming more acidotic, your serum potassium goes up. So again, it's back to this healthy diet with a focus more on plant-based foods. Of course, some foods have more potassium than others. For example, things like avocado. So you would recommend, if the patient is very hyperkalemic, you would ask them to restrict it. And also, for example, if we say don't eat bananas, that doesn't mean that they shouldn't eat any bananas, but they can eat like a part of a banana. rather than the whole thing. So you can limit the total potassium intake in different ways. Right, so it's the same case, but now let's see if we have some idea about how to manage him. So a 68-year-old patient with diabetes, hypertension, ischemic heart disease, a non-smoker, feeling well with fatigue and a bit of edema. Blood pressure is 160/90, so now that's above our target. BMI is 22, which is good, right? We try to risk stratify him using our CKD heat map. So his EGFR is 35. He's got lots of albuminuria, so he's in stage G3 and A3. So we know he's at high risk of progression. HP is 9, right? So the HP itself is not a reason to treat, but he has fatigue, which may be because of that. We look at the transferrin saturation, which is 18%. That's lower than our target of 30%. Serum ferritin is also 150, so it's lower than our target of 500, right? So there's scope for replacing iron here. His calcium and phosphate were within normal limits. We were able to do a PTH. It's 1.5 times the upper limit of normal, right? So that is still within what we would accept for someone with this degree of CKD, which is 2 to 3 times the upper limit of normal, right? Serum albumin is a little low at 3.2. We do the serum bicarbonate, it's 21, so it's a little low, but not low enough for us to treat just for acidosis. His potassium is 5.1, so it's a little bit high at the upper limit. We didn't do a serum uric acid level because it's not going to change our management. So what are we going to do? He's a diabetic. We want to make sure his blood sugar control is good. We aim for an HbA1c of less than 7 with appropriate medications. We give him some general advice to delay CKD progression and reduce the cardiovascular risk. So lifestyle, we advise him on a low salt, low phosphate, plant-based diet as much as possible, increase activity. We want his blood pressure to come under control. We prescribe an ACE inhibitor and ARB. Keeping in mind, of course, that his potassium is 5.1. Aim for an SBP of around 120, right? Because of the potassium, we might consider starting a bit of furosemide, and we have to keep an eye on the potassium. He's over the age of 55 and he's got CKD, so we're going to start him on atorvastatin. He should be on a statin anyway by virtue of having diabetes and being over the age of 40. And we're also going to start him on an SGLT2 inhibitor like empagliflozin. Why? Because he's got an EGFR of 35. Then with regards to his complications, we recognize that he has anemia, he has fatigue, so we'll start him on some iron supplements. We'll check what's happening with his hemoglobin. If it's not going up, we may need to give him some erythropoietin to improve his hemoglobin. With regards to CKD mineral bone disease, he doesn't need any calcium or vitamin D at the moment, but we'll need to monitor the profile to see whether things are getting worse. He still does have scope for a low phosphate diet. So low phosphate diet is basically the healthy diet we were talking about, which is low in processed foods. And with regards to the acidosis, again, it doesn't require treatment in itself, but if we notice that the patient is becoming hyperkalemic, we might start sodium bicarbonate for that. So here are some of the key learning points that I wanted you to reflect on from this case. There are new drugs that are, it's not really new actually, there are drugs which are proven to have effects on delaying CKD progression and improving mortality. These are SGLT2 inhibitors and are ACE inhibitors and ARBs. And the uptake of these drugs, the prescription of these drugs is very low. So SGLT2 inhibitors are of course new on the block, but ACE inhibitors and ARBs have been there for a long time, and even so, the prescription rates are quite low. So we need to focus on giving these drugs to these patients. There are newer drugs, of course, in diabetic kidney disease. I've just included these here for completeness, but they are not available for us at the moment. There are also many unproven treatments on the market, which are marketed as delaying progression, and I think we need to be careful not to prescribe these drugs to patients because they are costly, right, and they don't have any benefit. Our focus should be on the proven treatments, which I have mentioned. Some of the therapeutic habits that we have, the things we do as reflexes, may actually do harm, such as the routine prescription of calcium and vitamin D analogs. And I think communication is very important because often what happens is people prescribe calcium or vitamin D or any of these unproven treatments not out of any ill will to the patient, but because they feel that there's nothing that they can do for these patients. So one thing is there are proven drugs which can be used, and the other is that we just need to explain to the patient that these are the things that we can do, and try to keep them engaged with their treatment, because there are many things, even though they may not be as interesting as prescribing drugs. There are many lifestyle changes and so on which we can advise. Right, so just a few words about renal replacement therapy, because I think that's a very specialized area. The best form of renal replacement therapy. Now, even if we do try everything we can, many of these patients will go on to end-stage kidney disease. And the best form of renal replacement therapy is a transplant, right? So transplants can be live donor transplants or cadaveric transplants, and we are doing both of these in our government hospitals. Sometimes patients can go on to a transplant before going on any kind of dialysis, and that would be the best outcome for a patient. But sometimes patients need dialysis before they have a transplant. And then there are two kinds of dialysis, HD and PD, so it's hemodialysis and peritoneal dialysis. Both of them need some kind of preparation, right? So their patients need to be referred to nephrologists in advance so that this care can be planned. And hemodialysis is best initiated via an arteriovenous fistula. So again, for that process to happen, they need to be within a nephrology clinic and referred to a surgeon for the procedure. So ideally, patients with an eGFR of less than 20 should be referred for planning of vascular access and transplant. And we should aim to avoid crash landing. Crash landing means when patients arrive as an emergency in end-stage kidney disease and need emergent dialysis, because that is a life-threatening situation. Right, so moving on to the final parts of my talk, you may be wondering now, whom should we be screening for chronic kidney disease? Because we talked a lot about how to diagnose and how to manage these patients, but often by the time they come to the nephrologist, a lot of the kidney function is lost, and the writing is really on the wall for many of these patients because there are limitations to what we can do. So we really need to identify these patients early. So we need to screen patients who have risk factors for chronic kidney disease. Who are these people? Patients with diabetes, hypertension, cardiovascular disease, right? Patients from CKD area. So that was what I showed on the map at the beginning, generally the North Central province. If they have systemic diseases which may have renal involvement, like systemic lupus erythematosus, I should also have mentioned here if there are any drugs which can cause renal involvement, renal impairment, like NSAIDs. If they have urological diseases, so often we see patients who are being followed up in the osteoarthritis clinic receiving NSAIDs for a long time, or patients who are in the urology clinic who are under urology follow-up for a long time, and they haven't had a single creatinine measurement, maybe even blood pressure measurement, right? And that is really a lapse in our health system if we have not identified that these patients are at risk and check their renal function, right? So if you come across patients like these, make sure that you check the eGFR by looking at the serum creatinine and identify patients who have CKD. And of course, if there's a family history, then also we should be screening patients. So how do we screen? By looking at the creatinine and calculating the eGFR and the urine albumin creatinine ratio. If they're abnormal, we make sure that they don't have AKI or acute kidney disease, so basically that they don't have an acute problem. And then, just to demonstrate chronicity, we will repeat the eGFR and urine ACR in 3 months. So a few words about when you need to refer patients to a nephrologist. So a lot of these patients will be within the scope of the management of a general practitioner, especially the category I mentioned, that is CKD G3, where the GFR is between 45 and 60 with no albuminuria. Right, so that's the bulk of patients with CKD, and they don't really need to be referred to a nephrologist. We need to be aware that they have a high risk of cardiovascular disease and institute those steps that I talked about. But some patients do need a nephrologist, and I think that is one is when their diagnosis is in doubt. So if a patient doesn't have any risk factors for CKD but has a high creatinine, then we need to find out what's going on, right? When the cause of the CKD is in doubt, like if you have a patient who's got an active urinary sediment, so what we mean by that is lots of red cells or casts in the urine, that suggests that that's an intrinsic kidney problem, that this is not just due to diabetes or high blood pressure, the usual things, right? Then you need to refer to a nephrologist just to make sure that you're not missing something. And if you suspect an acute kidney injury, often you will have patients with established CKD who are in your follow-up. So these are, chronic patients. And then you need to pick up things which are not in keeping with the natural progression of CKD. And such patients also need to be referred to a nephrologist. So if the GFR is changing very fast, as a rule of thumb, we say more than 5 milliliters per minute per year. Or if the albuminuria is getting worse very fast, for example, if it's doubling, then we wonder whether there's something else going on in the kidney, and that's why you need to refer to a nephrologist so that this can be investigated. If there are complications which are refractory or which you find difficult to manage, then again you should refer to the nephrologist. And when the GFR falls below about 20 to 30, they should be seen by nephrologists for planning of renal replacement therapy, right? So there are only about 35 to 40 nephrologists in the country. So the bulk of these CKD patients will actually be managed by non-nephrologists, which is why it is so important that you understand how to manage these patients and whom to refer when necessary. And finally, I just want to emphasize that prevention is much, much more important than treatment, right? And the strongest risk factors for CKD in our country, despite CKDU, are still diabetes and hypertension. And every one of us, by virtue of being South Asian, is at risk of diabetes and hypertension. So we need to screen ourselves and our patients for diabetes and high blood pressure. And if they are diagnosed, we need to make sure that they are managed appropriately with follow-up and that we have the drugs that we need to manage these patients. There's a lot of obesity in the community that needs to be addressed. We are all guilty of poor dietary practices, so we need to address that maybe even at policy level, right? Because otherwise we are going to have an epidemic of diabetes and end-stage kidney disease. We need to increase physical activity, and we need to think about becoming advocates for kidney health. So that concludes my lecture, and I'm very happy to answer any questions that you have.
A lot of questions have been asked on SGLT2 inhibitors. So let me summarize all those questions and then let's go one by one. First thing they had asked is to enlist some of the drugs that belongs to the particular class. If you can just run through.
So what's available currently here is empagliflozin and dapagliflozin.
You mentioned during your presentation that SGLT2 inhibitors should be stopped during acute illnesses. So the question is, can you please specify what these illnesses are and the science behind it?
So that particularly in conditions where the patient can become dehydrated, right? But also in any kind of acute illness. The reason is that SGLT2 inhibitors can cause what is called a euglycemic ketoacidosis, right? Which is where the patient's blood sugars appear normal, but they have an acidosis, and that can be difficult to identify and also to treat. So for that reason, we ask patients to stop these drugs when they are acutely unwell, because there's no particular advantage of them being on that drug in the short term. So 3 days off the drug is not going to do any harm to them, whereas the benefits are really in the long term.
Right. So and then another question is lower cutoff of GFR. We can safely start a SGLT2 inhibitor.
Yeah. Yes. So the SGLT2 inhibitors can be started up to a GFR of 20. So below 20, we don't start it. We don't really expect them to work that well also when the kidney is not working properly. That is the lower limit.
The other one is, can we continue SGLT2 inhibitors during hemodialysis in ESRF?
Yeah, so usually we would stop the SGLT2 inhibitors once the patient is on dialysis.
And another question is, what is the place for iron, IV or oral iron in CKD?
Generally, in patients who are not on dialysis, we try as far as possible to supplement iron orally. Once patients are on dialysis, generally oral supplementation is not enough, so we have to give it IV. Of course, once they're on dialysis, it's easy for us to give IV iron because they are coming to the dialysis unit where we get IV access, so we can give it while they're on dialysis. Before they start dialysis, if we find that their HP is not improving and their iron stores are not improving with the oral iron, then we may again opt for IV iron.
And the next question is explain the BP targets of DKD with albuminuria and without albuminuria.
So, very conveniently, our latest chronic kidney disease guidelines have one target for everybody. So, it's a systolic blood pressure of 120, regardless of diabetic status, regardless of albuminuria status. There's no diastolic blood pressure target, again, just to make things very simple. So just aim for a systolic blood pressure of less than 120. Again, remember, these are standardized office blood pressures. So we just want to make sure that the patient is able to really tolerate that target as well, right?
And until which level of total cholesterol should we prescribe statins?
So that's again an area without much evidence really. There's no target as such in this category of patients.
Right. Then we have, is the proteinuria in CKDU lesser than the nephrotic range?
Yes, so CKDU is an interstitial nephritis. So it is characteristically a non-proteinuric form of chronic kidney disease. So it's definitely not nephrotic range, yes.
Then we have again, there's a question on, a broader question on lipid management of ESKD patients. Just an overview if you can.
Of ESKD patients, okay. So, yeah, so once patients are on dialysis, of course, the evidence for this, for initiating lipid lowering drugs is less. So generally, once they're on dialysis, we wouldn't start lipid lowering drugs just as primary prevention. Of course, if they already have established ischemic heart disease or any other evidence of atherosclerotic vascular disease, then we would continue whatever statins that they are on. But we wouldn't start just as primary prophylaxis if they're on dialysis. If they've already been on it, we would continue it.
Next is, what are the first choices of drugs in patients with established CKD for hypertension, diabetes and dyslipidemia separately? The first choice of drug in patients with established CKD.
Yeah, so established CKD, that's a whole spectrum. But when it comes to blood pressure, the agent of choice is ACE inhibitors or ARBs. When it comes to diabetes, now the first line drug would be an SGLT2 inhibitor, right? So if the GFR allows, so if the GFR is more than 30, you would give these patients metformin, right? So metformin, you need to reduce the dose, halve the dose if the GFR is less than 45. But we stop it once the GFR is less than 30. We should also be starting these patients on SGLT2 inhibitors because of their proven cardiovascular and renal benefit, provided the GFR is more than 20. And for dyslipidemia, of course, usually we prescribe a statin.
So then we are getting pouring with questions actually. What are the cutoff of TSAT and serum ferritin to start oral iron and IV iron?
Yeah, so the targets are the same. So we are keeping things simple. The transferrin saturation, we want it to be more than 30% and the ferritin more than 500.
And also, is metformin safe in polycystic kidney diseases?
As far as I know, there's no reason why they should be unsafe provided the GFR criteria are met. So if the GFR is less than 30, we would stop it. And if the GFR is less than 45, we would halve the dose. I don't know of any other reason why it would not be safe.
I think we go to the final question for the day, that is, what are the trials for non-diabetic CKD with regard to SGLT2 inhibitors?
Okay, so there are two main trials. One is the DAPA-CKD trial, which looked at dapagliflozin in the setting of proteinuric chronic kidney disease. And so this included diabetic and non-diabetic kidney disease, and it showed that dapagliflozin delayed the progression of chronic kidney disease regardless of the diabetic status. And then there was a second trial, which was the EMPA-Kidney trial, which included both non-albuminuric and albuminuric patients, both with and without diabetes. Again, empagliflozin reduced the progression of chronic kidney disease, regardless of whether the patient had diabetes or not, and regardless of whether the patient had albuminuria or not. So that is why this evidence that I described came from. So it's important to keep in mind that patients who have albuminuria are the ones who fall into the red boxes on that chart, and therefore are more likely to develop end-stage kidney disease. So they are therefore more likely to benefit from these drugs. Whereas the patients who have albuminuria, if you're thinking of absolute terms, if they don't have albuminuria, they are less likely to progress to end-stage kidney disease. Therefore, in absolute terms, they may not benefit in as much as those who are as those who are albuminuric. So when we are living in a resource limited setting, we should be prioritizing giving these drugs to the albuminuric patients more than the non-albuminuric patients.
Well, I think we have answered all the questions, and it was a very complete lecture on CKD, what we should know, and I think most of the questions were answered, and I thank all enthusiastic participants who had been shooting questions at us and listening to the lecture, and thanking the lecturer as well. So with that, we will conclude today's lecture. I would like to thank all GMOA branch unions which connected from all four corners of the country and facilitating the members to refresh their knowledge and also enabling them to gain national CPD points. So I would also like to remind the participants as well, do go to the Ministry of Health website where you get the staff access link. In the staff access link, you get the national CPD points link. In that, there is something called registration of mentees. Do register yourself there so that your CPD points will be carried forward and will be registered in the Ministry of Health as a participant for the national CPD program. So that concludes the academic cover for this week. Hope to see you in a fortnight's time. Have a good day.